call this meeting to order, the October 11th, 2023 Program and Budget Meeting. All rise for the Pledge of Allegiance. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Now, a reading of the mission statement. Lori, will you please read the mission statement?
Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence.
Thank you. Now, item number 3, adoption of the agenda. Is there a motion to adopt the agenda?
Support.
All right, motion by Donna, support by Lori. All in favor? Aye. Aye. All opposed? Motion passes. Agenda is adopted. Hearing of the public. Is there anyone from the public wishing to speak to this board? All right. Item number 5, request to approve 5A, AMSR assessing and managing suicide risk outpatient manuals. Is there a motion?
So moved.
Support.
Motion by Lori, support by Wayne. Thank you.
Hello. My name is Jeff Clark. I'm the nursing administrator. I formerly worked in the training department. That's why I'm up here right now, is because they asked me to appear for you guys. The ASMR books, or actually AMSR, as a part of the CCBHE initiatives, we are required to adopt the zero suicide policy. A part of that, we started doing the question, persuade, and respond, which is QPR trainings, and the AMSR trainings for case managers, therapists, and supervisors and nurses. Not only just our directs, but also our contracted agencies are all offered the chance to take this training. The training department has conducted 3 full AMSR trainings already. So 3 classes of 30, so 90 people so far. There are an additional 4 classes scheduled this year and 12 classes scheduled in 2024. All the 2023 classes are already booked, and some of the 2024 classes are filling up fast. So ideally, we would like to provide the training to at least 270 clinicians system-wide, and that's why the request for 200 books is what's been requested so far.
Any questions? Thank you, Jeff.
All right, thank you.
All in favor signify by saying aye. 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 Opposed? Motion passes. Item 5B, OST Master Service Agreement, NDA, and Statement of Work. Option 2, is there a motion?
Support.
Motion by Phil, support by Wayne.
Hi.
Aye.
We engaged with OST to provide us some external and internal risk testing for our IT environment. This stems from, we're currently doing a mix of things to satisfy this requirements for some of the other audits that we do, but as of this year in the contract that we have with the state, they require their contracted entities to have an independent ongoing security assessment year over year. So we searched for a vendor, and OST came recommended from some of my other counterparts in the CIO forum, and they had worked with them both at their PIHPs and elsewhere. And so we engaged with OST, and they already have experience with similar organization stars, so we thought it was an obvious fit. And so we're proposing that we contract with them. Any questions?
This has been recommended by legal or reviewed by legal?
I believe so, yes.
Okay. Thank you, Thomas. All in favor signify by saying aye.
Aye.
Aye. All opposed? Motion carries. Thank you.
All right, thank you.
Oh, you're coming right back up, I think.
Oh, yeah, this guy.
Renewal of lease and maintenance agreement with Applied Innovation. A motion to send to the full board.
Support.
Motion by Linda, support by Lori. All right. Hello.
Dan Gill. I'm an information technologies administrator. This is a update to our current lease with Applied Innovation. It's right sizing our printer fleet, refreshing the leases on them, the maintenance, and adding a production print shop to our training department so they can in-house their materials.
Yeah, and so some insight there, just for the board's awareness. They typically send out some of their larger print jobs to the county print shop, and that leads to potentially long lead times. So if there is a training that needs to be provided, due to like an emergent need or anything, it becomes a little bit difficult for them to do. So we had worked with the company that we already have the leases through to upgrade that proposal to give them a more a system with a higher page count and enable them to replicate what they're doing with the county to respond to some of those needs.
Okay, thank you. Does anyone have any questions? All right, all in favor signify by saying aye. 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 All opposed, motion carries. Thank you. Thank you, thank you. There's nothing to receive and file, and there's no resolutions. Other possible agenda items, Finance Department presentation. Tony.
All right, good evening. Tony Gaglio, Finance Director. You get to hear a presentation about finance. I know you were all waiting all day for this.
Oh, yeah.
All right, so what are we going to talk about today? I know once a month, you get this beautiful packet with all these financial numbers. We spend some time reviewing and understanding what our financial position is, right? Well, how does all that happen? And that's what we're going to talk about today, and that is our finance department. We want to take some time to acclimate the board to some of the staff. You may or may not be familiar. We've had some changes, and then importantly, what are those things that we do day to day? So that's the basis of my presentation. So I think everyone knows the characters displayed on the screen there, so we'll keep moving. But this is the important thing, the team. And the way we're currently structured is we have 5 financial administrators, each with specific responsibilities that are our functional areas that we're going to talk about in just a moment. So under grants management is Heather, and she has Diane, that is her fiscal analyst. So of course they manage all of the grant activity and all the reporting related to that. Under budget, audits, and analysis is Dawn Pratt, and she has Jessica as her financial support. So they are the ones obviously working on the budget. Now we're getting into the audit season, preparing all those audit schedules and keeping us on task there. For accounts payable and the provider payments, so every week we, of course, pay all of our provider network. We'll talk about that in just a moment, but Alex is leading that department along with Kendra and Mary Lou. Alex is a new addition to our department. He was actually at one point worked in county finance, then he had left Macomb County for a short time, and then we were fortunate enough to bring him back. Actually, no, he was back at the county, and then we brought him over to the best organization within the county, which is Community Mental Health. Alex has been a great addition. He's really, he brings a lot of that experience from understanding the county finance. He knows, Steve and the team, so it's been really great to have that knowledge base and the ability to communicate more directly with the county. And then on the general, actually another important point there, with Alex coming on board, as you know, the Raymond team was filling various positions. One of the positions they were filling was the administrator role for accounts payable. So with Alex coming on board, taking leadership over that, we were able then to reduce our dependency on the Raymond team. And that is one of our overarching goals, as you all know. Then on the general ledger side is Chris, and Chris has Patricia. Patricia's been with us, I think, just over a year, so she was another addition to the department. And then the two of them handle all of the general ledger activities and revenue and cash. And then finally, the billing and the coding and the claims function, and that is Kristen, along with our billing folks, Clarissa, Andrea, and Brandon. And Kristen is a Raymond employee, and that's one of the areas that we're looking to, at some point, be able to successfully recruit with the knowledge that we need to take over that function. So that's the team that makes everything happen. I put a little footnote there. We have a couple employees that have been here 20 years or more. That's Mary Lou and Diane, and they're actually going to retire. I think their last day is mid-January, so we're going to plan for that transition. So we'll have a little bit of a change in the department once that happens. So the next area is, what are our primary responsibilities? So sometimes we talk about these are our main functional areas. internally, sometimes we use our bubbles. Like, what are those things that we need to do and have key responsibility for? So the first is around revenue capture, compliance, and reporting requirements. As you know, we have a few reports that need to be sent, whether it be to the state, whether it be to here to the county, and ensuring that we meet all those compliance requirements and that we're reporting all those timely and accurately. That's a big function of what we need to do within our department. And then the revenue capture, and where that is important is now with all the CCBHC work and all the appropriate billing for those services, ensuring that we're capturing that revenue and then collecting that cash. So big function there around our revenue. As you know, that's critical to what we do and complying with all the requirements for our Medicaid funding. The other primary responsibility is around provider payments. As you know, we move hundreds of millions of dollars or $180 million or more through this area. We process approximately 300 payments a week and averages about $4.5 million. So this is a really important function. The team under Alex are the ones that mostly coordinate this, ensuring that what we're receiving is accurate, that we're paying things timely, and that we're managing the vendors. Important thing there, I could probably touch on it a little bit later in terms of accomplishments, but this is an area where we've really made some improvements as well, really understanding our having a process in place for new vendors. And we have a process now to ensure that any new vendor comes in, we have the appropriate documentation, everything goes in the system, and we have good controls over who we're paying. And if there's any discrepancy or question, we have mechanisms in place to ensure that we're not inappropriately making payments, outside of our organization. And then another big piece there is our leased homes. As you know, we still lease quite a few homes, ensuring the payment oversight and the pullbacks that need to happen. There's an accounting function that needs to happen as we manage these homes. That's a big piece under the provider payments. Billing, coding, and claims. So we have all of our direct run services. We're seeing consumers, we're billing for those, and where appropriate, billing out to insurance companies to receive payment. And then the CCBHC. What that does now in our department, we have a larger portfolio of accounts receivable. As opposed to our Medicaid, which is a capitated, we now have to manage this area more closely. And this is a growing area, as you know. So there's several $1 million of payments that flow through here, and we have to have good processes in place to ensure proper coding and then proper payment from those carriers. So there's an important function there. And the next one is around grant management. We currently have about 25 to 30 grants from different areas. A lot of these are around the SUD, but we do still have some grants that come through our mental health. Very important there that we meet all of those reporting requirements. We want to be in very good standing with those grant, the fact that we're recipients of those, and then ensuring that we're spending and applying those funds in accordance with those grants. So that's another function. Then general ledger accounting and reporting, probably the most exciting part of but the most important, right? And this is ensuring that we're capturing all this information accurately, keeping our cash reconciliation up to date, and then the production of the monthly financial statement. So all those detailed transactions every day, all the cash and the revenue, Chris and her team manage all of that to ensure that by the time it comes to this meeting, we can produce financial statements for this board. And the final point here is around supporting other departments. As you know, all of our departments, there's a financial component to the work that we do. And we do our best to try to support our colleagues. Some of that is just regulatory questions. Can I fund this? Can we pay for this other item? So we get a lot of questions like that. From the provider side, a lot of rate requests. And we've been working really hard this year to work closely with network ops. So network operations is talking to the providers from a contracting perspective, and they'll often come to us with requests for rate increases, right? My expenses have gone up, the environment has changed, we need to be paid more. And we're working now very collaboratively so that when those come through, there's a financial review of that. And when we approve or when we negotiate any type of increase, that it's a collaborative effort. So that's an area that we are supporting now. We get a lot of questions around billing and coding. Sometimes it gets very complicated to bill appropriately for services. So the team there answers questions from our direct run staff as well as our DCOs to ensure that they're doing that correctly. And then we have a variety of committees and work groups, and we do our best to participate in those as well, whether it be utilization management, quality, and then several other work groups that happen. We're part of that. All right, so what are some of our current priorities? There's a lot of activity, as you know, because you guys spend a lot of time, you talk to Dave, you know that we have many initiatives. So a few of the things I'm going to point out today in terms of our department priorities, of course, the audits. We have the financial audit that's just underway now, so we need to ensure that we work through that. We have our compliance audit that happens once a year, and then our Medicaid verification audit. So managing these audits and ensuring that we provide the auditors with access to the information they need is one of our current priorities. Something that we're also doing, and you heard Dave a lot talk about being data-driven and performance metrics. So there too, we are working to develop some key performance metrics, working with our informatics department, and can we understand our indicators better? Because everything that we do, we might understand the utilization and the volume, but do we also understand the financial component to that, the cost and so forth? So this is a big area that we're going to put some time in this year to ensure that we're doing that. And then, as we mentioned earlier, implementing the department org structure. We're continuously working with Ken and Kristen to ensure that we have a timeline and a good plan to transition the knowledge that they have and some of the responsibilities they have, and really empower our team and take ownership over those functions. And that's a continuous process. It's not going to happen overnight, but it is one of our priorities to continually transfer that knowledge from the Raymond Group to our team. And, as you know, there's a lot of expertise coming from Richard and that group. We may not be able to grab all of that, but we need to take responsibility for the things that we need to manage in our department. So that's an ongoing priority as well. Then implementation of the tiered rate model. I think you may have heard about that. So all of these providers with our group homes, many of them had just very different rates that were set probably years ago. And under Dave's direction, we have an initiative underway right now where we've implemented a new process where we are going to ensure that the payment for the services are in line with the needs of the individual, and ensuring that we understand in partnership with the case managers. We have a tool that's been implemented. So we're looking at their individual plan of service, and then we're doing what's going to be called a staff planning guide, which will assess the needs of every individual in these homes and then ensure that we're funding them appropriately. So some may get more and some may get less, but it's not going to be driven by the cost to the provider. It's going to be driven by what are the care needs of the individual so that they can receive the service. So big initiative, but we feel really good. We've done all of the training of all of the providers. Now we're in the implementation stage. So between now and January, we're going to be working with every provider home and systematically moving them to this new process and this new payment model. And I even noted there, so we're looking at, there it is, 58 providers, 235 homes, and approximately 600 consumers. So this could be a big task, but we feel real confident we have a good team in place to do that. The other thing that we're introducing now is value-based contracting. So we have a work group that Thomas led to get some foundational work done, and now I'm going to step in. And the point there is to really create contracting models that ensure that if our providers want to be incentivized financially, instead of just asking us, hey, give us a rate increase because our costs are up, what we really want to align that with is, are they helping us meet our goals? For example, we need to see an improvement in intakes. We need to see an improvement that those individuals are being seen within 3, 4, 14 days. Well, how are our providers working with us to achieve those? And if they are, how can we incentivize them financially to help us meet those measures? So we're developing some models around that, and we'll bring some information once we have some data around that. We'll bring it back to this group because I think we're going to be we're going to pilot it with intake, see if we're aligning the right incentives, getting the behaviors and the performance that we want, and then eventually spread this across other other areas of service. So this is again an big task, but I think if we chunk it out, take a piece at a time, that we'll be able to make some really positive changes in our contracting area. Okay, some recent accomplishments. Again, ensuring timely submission of our reporting. That's just one of the things we need to do. Improved efficiencies. Now, some of this happened some time ago, but I think it's still an important point. We were paying a lot of our vendors through checks and moving them to an ACH model, which is much more efficient for our team, much more secure because you don't have all these checks that have to go out. I think we're at about, we were at about 10%. We're probably closer to 80% now. When I put the stop point together a few months ago, it was a bit lower. And we encourage all of our vendors as they come on board. We've given them the first option of being paid by ACH. And there are a few stragglers, of course, that still want the check, but we're making good progress. And then the other improvement efficiency, I mentioned earlier about providers wanting rate increases. And those many times would just come from emails or just different communication. So we've been able to structure at least some consistent process. We have a form now that we ask them to fill out that captures key pieces of information that help us understand why they are asking for a rate increase. And it helps us evaluate. It's not perfect, but it's a great start. So at least our providers now know if they want to ask for a rate increase, they need to fill out that form, provide the appropriate support, and then we can have a very informed discussion about why they want a rate request. The budget, as you all know, we completed that, made our final presentation today, so that was a good accomplishment. And then Dave has talked to each of you, of course, you know about the capacity building grants. As at this point, I think we received about 25 to 30 different types of grants. About 12 of them are in some level of approval. A couple of them have already come to this board, and there are going to be some others, and that managing that process is an important thing and having that structure in place. All right, and then looking forward, the way I wanted to talk about this is moving from processing tasks to an increase in data analysis. And the technology that was implemented a year or so ago is going to help us in this. And instead of processing and moving paper, how are we using our time to understand what is happening? And the technology is helping us in our processes to move from just processing, I just pay this invoice, to asking questions. Why do we pay it? Is it an appropriate amount? Are there other ways we can do these? And as we're freeing up our staff's time from doing less processing, we're moving to what I'm calling, data analysis, asking those questions, and that's where process improvement comes from. So that's a focus that we have, and as I noted on my slide here, asking why. Don't just do it, it's just what we do. No, ask why do we do this? Is there a better way of doing it? And then projections and looking forward. An example there, I'm working with Dave right now just to be sure that we're projecting out, for example, our general fund spend. We already have a plan where we know we think we want to spend those dollars, project it out, and then monitor that. So whenever Dave comes in my office and says, how much more can we spend in the general fund, I should have an informed answer for him because we're already projecting that out. So that's one of our goals. And then again, anywhere where we can help improve the organization, provide our financial support, because there's a lot of other things that are being done in the organization, and we're here to help. And then finally, some challenges. As you all know, the impact or the full impact of the Medicaid redetermination, we still don't know the full impact. We know that that's going to have a financial component to it, so that remains as a potential challenge. And every once in a while, the state sends some new directives and some new initiatives that we must comply with. So that is, of course, sometimes a challenge and one that will probably continue. And I gave a couple examples there, whether it be the coordination of benefits, conflict-free case management. We could probably go down the alphabet, and there's several others. Provider rates, inflation, and increasing cost. Even though we're putting some structure in place, everyone knows the external environment, the cost to our providers. So this will be an ongoing challenge for us to hear their concerns and balance that with what we can afford to pay them and so forth. That'll be an ongoing challenge. And the final is the recruiting and retaining our skilled staff. So that will be an ongoing effort as well. We still have a number of unfilled positions. We obviously would love to have those filled, but we want, to the right people in those positions, then we want to retain them. All right, and then we have 3 key emails. What we do with these, if there's questions throughout the organization, we try to direct them to these 3 emails. And that way the question doesn't go to one individual, that person's out, and then our provider, whomever it is, doesn't get an answer for 2 weeks. This way it goes to this respective mailbox, and each person in that team gets the email so we can be more responsive to the incoming emails and requests. And that was an overview of what we do. I'll take any questions if you have them.
Bill?
Thanks, Mr. Chair. Tony, thanks for the presentation. Question and a comment. Going back to the tiered rate model, is that something unique to us? Are there other CMHs that are doing this? And if there are other CMHs doing it, which ones and how's it working out for them? Obviously, if we're going to try to adopt it, it must be pretty positive, right?
Well, I'll give the answer, and if I misstate something, Dave's right there, and he's gonna. Back in 2006, as I understand it, this was the model that CMHs should be on. So they're the one that our counterparts around the Tri-County area, for example, our other counties, they're already on some form of a tiered rate. So we're playing catch up a bit.
Gotcha.
But our purpose here, not only to be more compliant with the model, the state is, let me just make a quick side note, the state has a work group that Dave's been sitting on. I've participated on a couple of those meetings. So this is gonna be a state initiative regardless. Now they're probably months, if not a couple years behind where we're gonna be. But by implementing this, even if they change the assessment tool or they change the rates, we're already gonna have the foundation built, and we'll just be able to adjust to it. But the most important thing is those individuals who need high levels of care, ensuring that those providers are paid adequately, so there's no reason why those individuals should not be cared for appropriately. So that's the people first is the big element here.
Yeah, I think it's a good idea, and you actually, going along with that, you answered one of my questions, so I'll just make a comment on it because going to the cybersecurity part and the payment of the vendors, we recently had an incident in the county where we were scammed out of a lot of money, not CMH, but the county was. So to hear that we have the proper controls in place and processes in place helps me a lot, because that was a very intricate, unique scam that, a lot of money from the county was sent over to a vendor that we thought was requesting funds from us to be paid, and the county paid them. But it's nice to hear that we have steps in place for these vendors for when it is time to pay them, that we are paying the right person the correct amount and it's not going anywhere else.
No, absolutely. That's one of our main fiduciary responsibilities, right? We are stewards of these resources. On that point, this is gonna be one step, but now we are actually working on our procurement procedures and policies. We're gonna have a resource from Raymond. I think that came to this group last month. So this is gonna be a main focus area. So not only have those controls from a system perspective, that we have the right processes in place throughout the whole cycle. So we'll have an even tighter control, and just to ensure that we can do all we can to avoid those situations.
Thank you, Tony. Thank you to your team. Thanks, Ryan.
Thank you. And Linda? I'm sorry, Tana. I'm sorry.
I'll be Linda for this question.
Sorry. I'm sorry.
Time's up.
Okay. Referring to the providers coming for rate increases, you were talking about them possibly having to meet, I don't know if you called it criteria or benchmarks or, so is that something that you've also seen across the state, or would that be implemented like right away? Or is that something that you've seen in different areas?
Well, I'll start, and then Dave might want to
Okay.
add to it.
Yeah, I'm more interested
Personally,
in just
within
hearing
the-
what those
yeah.
criterias would be.
Within the CMH system, I personally have not seen it. Dave will be able to speak to that, but good business practice, and in my background in healthcare, that's what you're always striving for. You're always trying to align payment with objectives And when you can combine those and we're all, whether it be, you know, the provider, we're all working towards that same goal, that's kind of standard practice in other areas. Now, as far as CMHs, Dave, you might want to be able to speak to that a bit more.
Yeah, you covered that really well. Previously, we did not have standardized rates, so we had different providers getting paid dramatically different rates for the same service without a good trail about why that decision was made. Those decisions were made outside of the finance department historically. And when I started to realize those, so what we have now is we meet weekly with the finance team, and all of those requests go through that committee, that work group, and then working with Tony and Raymond, we've given the provider a template to give us some detail that would help inform our decision-making process. It's important that we have that transparency and that we're very open to our providers and that they know we're willing to listen to them and to consider differences. But overall, we're going to be have those standardized rates for the same service. We will make exceptions, and our system does allow for that. Some of you have heard me, I've called it structured chaos for a long time. We're working with people. So you can't make an ironclad standard rate schedule and go, these rates are for everybody. Because as soon as you do that, you're going to get that call and go, oh, well, yeah, obviously I need to pay. We're looking right now at some of the OT, PT, and speech services. Two of our providers primarily will actually send their staff out to the individual's home to provide those services there. Obviously, there's a cost difference between travel time and total time spent, and the no-shows and things like that. You know, you get to the door, you knock, and nobody's home. So it made sense to do a bifurcated rate for the in-home services compared to the clinic-based services. So our system is designed in that way. Again, it's the providers can easily contact us through one of those emails. We're very responsive. We listen to them. We take their issues into consideration, and we give them a very prompt professional feedback. So the process is working a lot better now.
Thank you, Donna. Any other questions? Linda?
Tony, do you serve on the Contract and Financial Issues Committee
Of the association,
No, that's the CFI group. I attend those.
Oh, good. I did once, but it was in a foreign language.
And
So we sent you, I think that's why.
we're pulling Ron into those meetings too, so. Yes.
Any other questions? I have one question, Tony, and that is value-based contracting and the tier. Is there a way you can explain both those tier rates and value-based contracting at like an 8th grade level, and just overall what those are?
Yeah,
I've read Tracy's emails about them. Just really
sure thing. So the tiered rate is specific to our specialized residential, so those individuals in a group home. And what we're doing there, instead of having your home with 6 beds and we're going to pay you X amount for everyone, what the tiered rate is going to do, based on the assessment of the need of the individual, we're going to have 5 levels of payment. So just by way of example, if this individual needs 4 hours a day of care, there's going to be a payment rate that's going to be associated to ensure that we're covering that cost. But there may be an individual who needs 8 hours of care, there'd be a higher rate. So the tier is really based on how many contact hours or care hours are required for that individual. So we're moving away. So that home that currently has 6 people and we're paying the same amount, when we're done with this, they're going to get 6 different amounts based on the needs of the individuals living in that home. Does that help?
Yes, it does help.
Okay. And then with all that, just as Dave
Is
said,
it different than value-based contracting, or is it?
Yes,
Nope, then the other side of this is value-based. So for example, right now, we are watching the data around our intakes. We know there's so many people waiting to get access into our system. And we know that there's provider capacity out there, or they could get very creative and create more capacity. So what we're looking at is, can we create a model that will help move that from a financial perspective? So for real, let's go seventh grade example. It could be, if you as a provider are demonstrating to us that not only are you increasing the number of intakes over a baseline, but let's say you're getting those individuals in a service within 2 days. Well, we're gonna pay you an incentive for that level of prompt access to service. Because in the end, that individual is gonna do much better than waiting 4 months, 6 months. So that could be just one real simple example, that based on how quickly you get those individuals into care, there'll be a payment stream associated with it. And then my thought is, if we can provide these providers with more payment through that mechanism, as opposed to them just coming to us and asking for rate increases because their costs have gone up. We'll pay you more, but you gotta help us care for our population better than we currently are. Does that?
It makes a lot of, other than the timing, I mean, that makes sense. The timing being one of the metrics to determine, oh, you're providing a higher quality service. Are there other kinds of ways that we can measure value other than, I'm sure there are, I'm sure
There's
there's
all
a lot.
kinds.
Yeah,
We've
and
been
we wanted to
historic,
start with intake because that's one, but yeah, depending on what it is we're trying to achieve may very well then create different criteria to achieve that, if that's
Okay,
kind of
yeah.
where you're going, yeah. Dave?
we've been historically fee-for-service. So in simple terms, you're moving from volume to value. You want to pay for outcomes that we're looking for. Speed of access being one. Then you can get more fine-tuned as we continue to improve on our data, to where, if these health indicators, if the person's quality of life are improving, you can do incentives for that. I've seen employment models based on this. So if the individual, you're able to move from job coaching to working independently, there's an incentive paid. Under a fee-for-service model, if you're getting paid to be my job coach, your incentive is just to keep
Keep me a
working
job coach forever.
forever and ever. You're doing my job for me. You're just continuing for me to be dependent on your services. And when you start doing value-based, then you're putting the dollars in line with the outcomes that you want, and then some really cool things start to happen. But we needed to honestly get better with our data reporting and tracking. And then on the finance side, we can now better project the impact, make sure we have the funds available to do that. And it's right in line with the directions from the board. You want us to be spending that money as best as possible here locally, supporting our providers. And it's all incentive based. We're focusing very much now on the carrot. Later on, we might look at some sanctions under certain conditions, but right now, given the situation, it's all going to be a positive opportunities for our provider system.
Dave touched on it, but just to put things together, this board supported the movement to create the informatics department in that position. The work that we're talking about would not be possible without that structure, because it's all data-driven. So these pieces go together.
There's a method to my madness.
Thank you. Those examples really helped. Thank you.
Thank you for the time. I appreciate it.
Thank you. Item 8B, CEO update.
Well, thank you, everybody. Tony, thank you. That was a really good presentation. Exciting things are going on in the finance department and across the board. As Tony indicated, a lot of that changed with the CCBHC demonstration. We had to do some changes internally there in finance. Clarissa was just in my office this morning. I was signing off on an AmeriHealth contract, so we'll be on panel with all these payers, so that when people come in to our clinics to get help, we're very able to see people regardless of what type of insurance they have. So, yeah, it's a lot of good teamwork going on in the finance department. You have, as a handout, I mentioned in my report at the last full board meeting that I had neglected to put information in my report about all the good work we're doing, reaching out within our communities. So this goes back August, September, and through the end of this month. Some of those community events that we've participated in. We're seeing a really big uptick in this, and again, we have a good solid core group of volunteers, but we're growing and expanding that as well. Really can't thank our team members who have been volunteering. Some of these are, evening and weekend events. They're loading up their cars and the wagons. Jeff's smiling. Jeff's been out to a number of those. It's really positive, and it's growing. So as you can see, we do track these, and we can do like a quarterly update to let you guys know what we're doing. If you hear of community events, please let us know and share. And then working with Airfoil, we are doing some target marketing efforts based on our experiences. Ryan and I were talking about children and being exposed to various substances, especially marijuana. There was the Senior Fun Fest, which was a huge hit that we participated in. The county's Office of Senior Services was point on that. But when we looked, what do we have specific to older adults? We didn't have much, so we're continuing to refine that. Very happy to report. Tracy, would you like to give the update on the pocket guide?
Sure, and you can jump in if I miss anything. So we're very excited. We're on the last draft version of the pocket guide. The pocket guide, just as a reminder, is the pocket-sized guide that's about this big. That the concept is the officer was developed originally by Lieutenant Gillespie of the Sheriff's Office. And imagine every page has like the most typical services that someone might need. As an example, it has, of course, domestic violence, substance use. It has our crisis center services. Those would be examples, but it's probably about 8 pages, maybe 10 pages front and back. It's color. It's very nicely done. And again, it's a very cool thing that officer whoever could put it in their pocket, and they have everything at their fingertips, but they could also leave it behind with somebody with all the important phone numbers, addresses, including they tell them like where to drop off a youth who maybe is homicidal, suicidal, and they give them very specific information there. It does have a few QR codes too for kind of to find additional information. So we have shared it with several local law enforcement individuals. Everyone gives this is great, we love this. We have a meeting with Lieutenant Gillespie, I believe tomorrow, to hopefully get some final edits. It was shared with the CAC, and we asked for that feedback, and we got all positive feedback on that. And we also had our local partners review it as an additional edit. So we're excited to have it hopefully printed and out in the public in the next couple of weeks.
Thank you very much. If you remember at our Mental Health Matters event last year, Lieutenant Gillespie was honored. In part, he does so many great things, but he made that guide. He pulled it together. He printed off, I believe, like 5,000 copies. When we looked at it, it just needed some updating. There have been changes in our system. So working with Airfoil and stuff, it's be a very nice professional. From talking to the police officers, they carry them in a box in the patrol car. They keep 1 or 3 in their pocket, and then they make it available to the people they're interacting with in the community. So we're very happy to have that. That'll be out on the streets here very shortly. Other than that, there are a ton of things going on, but I guess you'll have to stay tuned for my larger report at the full board meeting coming up. So thank you.
Thank you, Dave. Just a reminder, there's a recipient rights meeting on October 19th at 8 o'clock. And full board meeting is October 25th at 6. Is there anyone from the public looking to speak to this board?
So to continue on with the good news, Dr. Serpa has had a dream for the last few years of finding some type of laboratory service that could partner with us and provide laboratory draws right in the clinic. One of the first tasks she gave me when I first became an administrator was contact Quest, see what it would do to get that partnership going. Quest is great because they can link with our EMR. We get instant results if somebody goes to a Quest location. So I did get in touch with our Quest representative and was to find out that it would be possible, but they had a very large number of lab draws that they wanted monthly. And if we could not guarantee that, we would have to be financially responsible to pay the difference to help that partnership go through. So, without knowing the data of how many people will actually follow through if we have a phlebotomist on site, we chose not to pursue that and have looked elsewhere. In early 2023, we got a lead from one of our physicians that works at a different location that says, hey, this company's been helping us out. They can actually go to the house and do the lab draws. So we started working towards a partnership with a company called Helix. But unfortunately, as we were trying to develop that partnership, the contact with them became sparse, few were between, and then they just stopped responding. And according to Cranes Detroit, an article published on April 20th of this year, they had actually claimed bankruptcy, and that's why they were no longer contacting us. Dr. Serpa continued her search, and she found a company called Vibra Healthcare Laboratories. They have been very receptive, very interested in partnering with us. The only data I could really provide to her from our informatics department was what antipsychotic people were on, because it's like this number of people is on antipsychotic. That would mean that they should typically get labs at least yearly or monthly if it's a clausural person. So what we were able to do is present the data of, these are the people that should have labs drawn if the, prescriber is following policy. With that, VHL was excited, and they are starting with us on October 23rd, 2023. They will be providing a staff person that can collect blood, urine, and buccal swabs for testing according to whatever prescribing order has been ordered, and based on the consumer's medical necessity. The staff person from the lab will be at the west locations Mondays and Thursdays, and the north location Tuesday, Wednesday, and Friday. This will offer individuals another choice of treatment and encourages those individuals that may not have a great history of following through with getting the labs done, just being in the office and getting encouraged to do them right there on the spot. So when they get the prescription, hopefully we can engage them and get them to follow through with that. Of course, they still have their freedom of choice, whether they don't want to do the lab at all or go to their, primary care provider or, laboratory of choice. Again, this allows our prescribers to get the results that they need to provide proper and safe treatment. And the best thing about this is we're not being charged with for this partnership. And obviously it's a trial phase to see if it's mutually beneficial for both of our individual served and for VHL Labs. But it's great that our individual served can come to one location, especially just in North. You can get everything you possibly need medical wise, except for dental now. All right, so that's what good news.
Thank you.
Oh yeah, for sure.
Like, for example, if my son gets his worker want to see blood test done because of his prescriptions that he's on, would I can obtain the script from them and then come to your lab and have them draw?
So because the way the partnership works, the physician has to sign an agreement with the lab saying, yeah, you can use my MPI to bill for that. Yeah, so.
I mean, I'm just thinking.
So your physician would actually have to partner with that lab. Now, if your physician already had an agreement with that lab, then yes. But ultimately, for example, if somebody maybe sees, like, the primary care doctor gave them a prescription for labs that they put in their wallet and they've been walking around with for a while. If they come in, see one of our providers agrees, yes, those labs are crucial, you need to get those done. Our provider can rewrite those labs and they can get it done that day. Okay? Yeah. And the pharmacy also delivers too, so if you need that service, they got that available. Any other questions? All right, thank you.
Thank you. Is there anyone else from the public looking to speak? All right, is there a motion to adjourn?
So moved.
All in favor signify by saying aye.
Aye.
We're adjourned. Thank you.